Welcome, listener, to today's episode of the Coriel Ortho podcast with me, Tony Wilkinson, consultant podiatric surgeon, foot surgery expert, and founding director of Coriel Orthopaedic Group. Now, this is a podcast where we delve into everything surgical, medical, and health and well-being related. Now, today we're staying in my own back garden. We're talking about foot and ankle surgery with my colleague Zain Abiddin, who is a consultant orthopaedic surgeon specialising in foot and ankle surgery. And I really want to get his opinion on things that might be difficult to treat, how he approaches it, which will help me in my practice and, of course, help the listener to understand pathology about foot and ankle. So welcome, Zain.
Thank you very much, Tony, for inviting me.
So
I really appreciate it.
The first thing I always want to ask people is, and this is always a question that gets asked me, why did you end up in foot and ankle surgery? I mean, foot and ankle surgery, especially in orthopaedics, was always seen as the Cinderella of the specialty. But of course, you specialise in that. So how did you end up there?
Well, I started my medical schooling a long time back. When I came to UK back in 1998, I went into my further training in orthopedics. And doing the orthopedics, I had developed interest in foot and ankle surgery. The anatomy itself of this foot and ankle is absolutely amazing. There are so many joints, I think more than 33 joints in the foot and ankle, about 24, 25 bones. The way the foot and ankle works is a brilliant anatomy and a piece of really marvelous architecture. And that attracted me towards foot and ankle. There's so many conditions we deal with. And so I got interested in foot and ankle and developed my practice in foot and ankle for the last 15 years here.
Great stuff. Well, certainly I agree with you on that. And, you know, I've always enjoyed the challenges of it. Now, recently we did an educational event down at the Coriel Clinic where we both work and co-own. And we talked about some of the hindfoot problems. And we started off with one of the conditions that can be very problematic in terms of treatment, tendinopathy, so Achilles tendinopathy. And the problem I find with that is that it's not like doing, say, a bunion correction or doing something that's absolutely definitive. So a patient comes in with pain and dysfunction, and it can be a very, very frustrating condition. Now, when I was explaining it to the people who were there, we have physios there, GPs there, we were using ultrasound, we explained that there were three zones to the Achilles tendon. There was the insertion point, where you can get insertional Achilles tendinopathy. There's the mid portion, where you can get the thickening and the tendinitis. And then there is the myotendinous junction, where you can get sort of minor tears. But the majority of pathology tends to be in zone 1 and zone 2. So let's take the insertional tendinopathy. When someone comes to see you with that problem, so it could be a bump on the back of the heel or just pain in the back of the heel, what's your approach to it? What's your go-to?
Yeah, the first is a very common condition, as you know, Tony. Insertional Achilles tendon, very painful. It can be quite horrible kind of pain and quite limiting for the activities. So when the patient, you take a detailed history, examine the patient. History-wise, are we talking about whether they had any injuries in the past, especially looking at whether patient has got any diabetes, whether they're overweight, patients who have got gout. All these medical conditions need to be ruled out first, and then I'm going to examine the patient. The patient, looking at where particularly the patient is tender, whether around the Achilles insertion on the bone itself or onto the tendon. Obviously, it's very important to examine whether the tendon is normal or not healthy. And sometimes you might need some more investigations, for example.
When you say normal, what do you mean by normal?
Normal in the sense you need to make sure the tendon has been intact. And sometimes
not
ruptured or something has come off. And many times patients have been ongoing grumbling pain over the months and months, and sometimes can go on for about a year and they maybe longer, and they somehow adapt to itself with this condition, and they get a prominent bone at the back of the Achilles insertion, and that can be quite troublesome. So my approach would be just history, then examine, and then investigate a bit more further. Usually ultrasound scan is good enough for them. I usually take a standing x-ray of the foot in a lateral view to see what the calcaneal pitch is. Sometimes you need a bit more technical here, but you look at where calcaneus is broadened or not, where there's calcific debris around this. Interestingly, we pick up a lot of patients with gout who do have kind of insertional issues, and all they need is management of gout. Occasionally, they might need a surgical intervention. And but again, first of all, confirming the diagnosis and then looking it through the scan imaging.
Okay. So you get a patient who goes along for a scan, and you can get those patients that come back and they may have some calcific change within the tendon, or you get those that have just a thickened tendon really, and it may have some neovascularity, so some new blood vessels in there and nerve endings which are causing pain. So let's say you get a patient who's got that lump of calcium going into the tendon, you can see that. What would be your surgical approach to that? How would you deal with that?
Yeah, before surgery, I think a slight bit of heel raise might sometimes help these patients a lot. Conservative treatment, putting some kind of a padding and cushioning out of the back of the heel, and they can manage that way. I'm a bit guarded giving injections on these, but occasionally there'll be an occasion where you will have to consider whether the patient's, for example, not fit for surgery or not fit for. It's worth trying an injection very carefully, but there's a tendency for tendon to rupture and avulse in 4 to 6 weeks after this kind of condition. So be very, very careful. Ultrasound guided, you can do a needling, and you can do and that can help with the pain a lot. But these are more insertional ones. Yes, you can continue with these physiotherapy, stretching of the Achilles and eccentric loading. Doesn't help very much in the insertional problems. It can help for the tendinopathy, for the mid-substance problem, the physiotherapy. But for invariably, they might need surgical debridement and cleaning.
Yeah. Okay. So when you talk about surgical debridement, how do you do that? Are you removing the excess bone there? Do you take the Achilles off the bone completely, or do you separate the fibers of the Achilles and reattach it?
So there are two schools of thoughts here. Some people tend to completely avoid the Achilles insertion. They go what's called as a Zadek's procedure, which you take a small sliver of bone from the back of the calcaneum.
So that's a wedge of bone.
Wedge of the bone is taken out, and the wedge of bone is taken out from here, on the bit of the here.
Yeah.
And then you close the gap, and so you take the pressure off the Achilles tendon that way.
Yeah.
I tend to prefer to go for a primary debridement because that way the primary pathology is. Where we tend to expose the back of the tendon. Obviously, patient is anesthetized based on the patient's choice. Day case procedure.
Yeah.
You go home the same day. You expose the Achilles insertional area, depending upon which part of the tendon is involved. Usually, it's on the outer side and central portion. And depending upon the extent of involvement, obviously, you had a ultrasound scan. Sometimes you get an MRI scan to evaluate the extent of disease.
Yeah.
And you open the tendon, clean the whole of the calcium built up, the extra bone. You excise that bit of the calcaneum bone, and you reattach it with suture anchors.
Yeah.
If it is a limited involvement, you can, suppose, avoid the full detachment of the tendon. Even if it were to detach the tendon, I tend to preserve the outer bands on either side. They go in the central.
Just on the outside.
Yeah, so at least they have a rapid good recovery.
Yeah.
Just about 2-3 weeks in a boot or a plaster cast.
Yeah.
And then you start mobilizing them depending upon the extent of involvement.
Yeah. I mean, certainly I do both the debridement and the wedge osteotomy. And I always find it, I think if there's calcification in the tendon, there's a lot there that you can see on the x-ray. Whereas if I get those ones where the tendon looks thickened or there's a prominence of the bone, then I'm more likely to do the wedge because there's not really a lot to remove from the tendon, if you see what I mean.
Exactly.
Does that sound right?
That's true. Sometimes what happens is there is evidence in medical literature which just suggests that even if you don't touch the tendon, just do a Zadek's kind of a heel osteotomy, and that'll be good enough. People have just managed not to touch the tendon. If you can take that into some kind of a weight-bearing x-rays on the foot can tell you exactly what the calcaneum shape is. Yeah. And if there are 3 different basically broad type of the shape, if there's a quite prominent posterior tubercle, then I think a Zadek's heel osteotomy, and there is some ratios which I don't want to go into too much technical about it, but you can do a Zadek's procedure.
Yeah.
But where the main problem around the Achilles insertion is, there is always a inflamed bursa. So when you open the tendon, you tend to excise the inflamed tissue, excise the bursa on either side of the tendon, and that seems to work very well in my hands.
Well, certainly that kind of part of the Achilles tendon anatomy seems more of a definitive thing. So you see something there, bone, you remove it, you reattach the tendon. When you move up the Achilles, you get into that mid portion, so the watershed area where you tend to get the ruptures. Often patients will come in with a lump in the middle part of the tendon, which is painful. You do an ultrasound scan, you can see that it's painful. Sometimes you might see some tearing within the tendon. And there is a school of thought that high volume injection works. Now, it's interesting that I was at a conference earlier in the year, and a radiologist called Otto Chan was talking about doing high volume injections, and he swears by it, and I something that I do use. But it was interesting because I stood up and said to him, Otto, I think you're looking at this through rose-tinted spectacles, because you're almost telling me that all of your high-volume injections always work. But in reality, what probably happens with a radiologist is that someone goes to see them, and when it doesn't work, they don't go back to the radiologist. For us guys, when something doesn't work, they come back to us. So what are your thoughts on high-volume injection? Is it something you do? And if not, what else do you offer these patients?
That's a quite a burning issue now at the minute with the chronic Achilles tendinopathy. Obviously, it takes about, some people, I mean, if you look into medical literature as well, what thing really works here is a physiotherapy, eccentric loading program, stretching of the tendon, and by about some conditions like these can be self-limiting. It can take about 18 months, but it can be quite painful, quite uncomfortable. So these kind of situations, my approach to them is physiotherapy first. I send them for a good 3 to 4 months of physiotherapy, and they do these kind of stretches 3 times a day, 20-minute sessions each. After that, I reassess them, and if there's still a bit of inflammation on the tendon on ultrasound scan, then yes, I tell the patient that you might benefit from a tendon brisement procedure we're talking about, like high volume injection with a low dose of steroid, but it has to be given very carefully. I warn the patients that there's a slight risk of tendon rupture with these. Again, you have to watch them for the first 4 weeks, 6 weeks, and based on that, I think many people do get quite a benefit from the injections. But obviously, you can't repeat these injections again and again. So I give only perhaps 1 injection and physiotherapy alone. There might be a situation that is gone for about 12 months, 14 months, 18 months, coming to that kind of a mark. I might just offer them a surgical decompression.
So when you say surgical decompression, I always think of this as a wishy-washy operation. That you cut the skin, you get down to the tendon, which has the paratine that surrounds it, and you might cut the paratine on, but it almost feels like you haven't done a great deal other than just cut the skin and cut the paratine on. So when the tendons thicken, sometimes, and it's not, I don't do very many of these because, like you say, most patients are resolved with conservative therapy. So do you take a section out of the Achilles to thin it? Do you debride the actual tendon itself, or are you just cutting the paratine on in the same way as kind of the stripping technique would be from a brisement?
Again, I'll try the patients to avoid surgery as much as possible for this condition. I'm trying to avoid, and then if I'm going to take a patient for surgical intervention, I'll definitely get an MR scan to make sure the rest of the tendons are okay, what tendons are available for tendon transfer in case the tendon is quite badly damaged. Many times they just get a tendinosis, we get a mucoid kind of a degeneration in the tendon, which is thickened, which is at the mid substance again, which is the watershed you talked about earlier. So I just do open the sheath, a small incision at the back, open the sheath and decompress the tendon with the sheath, number 1. Then I do a few vertical slits in the tendon, and that allows for
cutting into the tendon.
Cutting the tendon. I just do 4 or 5, and sometimes I worked with some of my colleagues who have done before just percutaneous, like a stab incisions, vertical, not releasing the tendon, not transverse obviously, but vertical slits, about 4 or 5, and that tends to generate the kind of a self-healing process where you get a neovascularization and start the healing process. Obviously, you have to be careful. If the tendon, I tell the patients that if I'm doing the operation, I find the tendon is quite more than 3/4 is involved, then possibly it might be a flexor hallucis longus FHL, which is a tendon for the toe, which moves the toe right near the nail, just kind of a movement, and I can transfer that onto the heel bone. So that's, I always tell them there's a slight chance for me doing that, but so interestingly, that's we haven't published it yet, but I think this is one of those things which I think when they have failed all the measures, what else option do you have? I mean, they're still in pain and they have just done the physiotherapy religiously and everything, and they have still got that's an option where obviously
I suppose it's difficult, isn't it, to actually publish anything on this as a single centre, because I can count on one hand in the last 5 years how many of these that I've dealt with, just because like you say, most people are cured with simple treatments. I think one of the most frustrating conditions that I find is heel pain, plantar heel pain. So patients will come in and say, I've been diagnosed with plantar fasciitis, and usually that's the go-to complaint really for plantar heel pain. And we tend to now call it plantar fasciopathy because it's rather than an inflammatory condition, it's more of a degenerative change of the tendon. And, same sort of thing as we discussed with the Achilles, using stretches, support, all of these things can be helpful. Do you use steroid injections on those? Because the evidence for steroids in itself is weak, or do you use it with a needling technique? What's your go-to with that?
Yes, again, before starting on a management of plantar fasciitis or heel pain, plantar fasciitis seems to be only one of the causes of so many different causes, if not 100. There are many causes for a heel pain. I would again take the history properly, make sure the patient don't have any treatable medical conditions. And interestingly, many of the people do get a very tiny stress response around the bone, or the calcaneum on the sea. They have got low vitamin D levels. Many of them will be having gout, high BMIs. And those things to be addressed before we manage the heel. Again, non-operative management.
Do you take routine blood tests for every heel pain?
I always
at the beginning, even if it's a singular one rather than a biological.
Every single case I do a serum uric acid. I do vitamin D levels, and I do a full blood count and make sure they don't have diabetes as well. So these 3-4 things as a routine checkup, I do it. Perhaps maybe over kind of investigating. But as usual, I've picked up loads of patients who have got a low vitamin D levels. And addressing those treats the pain quite well for this painfully. They've got micro fractures around, so you can see, imagine on this kind of a bone here, and these spurs here on here. I mean, those spurs are really kind of a red herring. So pain is around the sole of the foot here on the side, and many times they can come from the back of the calcaneum. So for these kind of conditions, I tend to first investigate, make sure no treatable causes, medical causes. I also be aware about patients having a referred pain coming from the lower back. If they got trapped between L5, S1 in the back of and they've got a referred pain, and that can sometimes be a sign of a radiculopathy kind of first heel pain. So always rule out if this patient has got a referred pain or not, and then refer to your spinal colleagues. Management again, failing all that, when confirm it with the ultrasound scan to see if the plantar fascia is thickened, and if it has got a classical pain on the origin of fascia, you stretch the plantar fascia and is tender, then I would offer them an ultrasound guided injection. While doing the injection, again about 4 or 5 pepper potting kind of a small needling technique around the plantar fascia helps immensely with this kind of things. In my experience, many people do get response. Some will come back again after 3 to 4 months that they have had injections and still not working, and they'll be very, very cautious again to see have you missed something on the medical diagnosis, for example, kind of things. And many of these people will do have very tight gastrosoleus complex, and that has to be addressed with physiotherapy again for about 3 to 4 months. So supportive management, symptomatic management, physiotherapy to stretch the gastrosoleus complex, and they do very well with the night sprints on top of it. So we started on this program with a physiotherapy first, ultrasound confirm the diagnosis, blood test to make sure there's not anything treatable, and then this kind of injection ultrasound. Interestingly, the steroid, that's the lowest. That's the thing which I would prefer. There is some weak evidence showing up. Some of my colleagues have done it, and looking at the PRP on these. I've done only handfuls of the PRP for plantar fasciitis, and again, it's whether the injection works or the needling works. It's difficult.
Whether it's the fluid that you're putting in just causing disruption. I mean, I still use steroid, but I always tell the patient that we're not quite sure that the steroid actually does anything, or is it just the fluid that we're putting in? It's the needling technique that does the trick. And I suppose it's one of those things, isn't it? It's very difficult to prove either way of what's actually happening, although the evidence in itself, it's pure steroid injections. But of course, if you give it blindly and you don't quite know if you're in the fascia area, or you could be in the fat pad, you've got all the other potential problems that can go with steroid, like loss of fat pad and all of that.
So injection I will do only about 2 in about 4 months, 6 months interval kind of thing. And then after that, if it's still very tight gastrosoleus complex and very still, I may offer them as gastrosoleus release, and that obviously very carefully on those kind of things, but not overdo it at the same time. But that's as far as close I'll go to surgery on these. Otherwise tend to avoid surgery.
And I agree with that. I mean, it is again another condition that I don't particularly enjoy operating on, because I think it's the unpredictability of surgery. I mean, I've got a guy at the minute who who's had recalcitrant heel pain. He's had ultrasound scan, he's had needling, he's had an MRI scan, which has shown a tiny undersurface tear, but I'm not sure actually whether the needling has created that problem. He's got a little bit of bone edema, which sometimes you see, so swelling within the bone, but it is grossly thickened. And he's, it's 2-3 years down the line now, and he's still struggling with that. And the two options that I have surgically are either plantar fasciotomy, which I tend to do ultrasound guided, so cutting the medial band, not the whole fascia. And it is a one operation where I tell patients to get back to normal more or less straight away. So off the table, just rest it for 24 hours and then, walking on it to try and stretch that out and get it. And I've had some good results with that over the time. I did publish a paper probably 15, 20 years ago now. It was only a small cohort, so it was only about 12, 15 patients, because obviously we don't operate on that many of them, and the results were reasonable. The other option, of course, is doing the gastroc lengthening, and I've done a couple of those, and I've used it for other things where I've needed to lengthen the Achilles, but I always feel uncomfortable when someone has heel pain saying I'm going to lengthen the outer muscle when it's away from the problem, even though we get the connection, just to kind of sell that to the patient, because they're like, well, you're lengthening that to treat that, because it's just the unpredictability of it. Have you done many? Have you good results with it?
Yeah, I've done a few patients with the plantar fascia release has been done before, and there was scarring there, and they don't want to go back again to that same situation. Then you do that. Interestingly, what happens is when human beings have grown from the quadrupeds, kind of walking the feet and then coming to the state, the calcaneum. So if you look at the goes from here, the calf muscles go from here, then it goes underneath the heel, and then becomes a plantar fascia. So it's a kind of one continuity of everything. So so calf muscles, the soleus, all three become like a tendon, Achilles tendon goes at the back of the here and becomes a plantar fascia underneath it. So the heel bone has just adapted and grown into the whole complex itself. All the other animals are like that, aren't they? They're the equinus. So when a human being came to that kind of plantar position, the calcaneum has come into and therefore I think it's tightness of the gastrosoleus does cause this. We can argue which one was the first with the plantar fascia. It started off and then got a stiffness. But releasing the gastrosoleus, you have to be very careful with these. I mean, if you have tried all the other measures of managing patients with the plantar fasciitis, with the pain, all injections given, this have not and still tight, then you'll do it but I won't offer it to anyone like a primary treatment.
Is it too soon? So if you do go to release the gastrosoleus complex, where do you do it? Do you do it as a high proximal medial calf with just a fascial release on that, or do you do it more on the gastroc aponeurosis lower down in the mid portion of the calf?
My approach is a middle portion kind of thing. Right. Yes, but also there's proximal ones that is well documented and established where you do a gastroc on the medial belly of these. But occasionally, I think in my practice, in my hand, I think it's the gastrosoleus in the middle part is much better, like a straight kind of procedure.
Right. Do you cast them after that? Then you keep them non-weight.
I cast them only for the first couple of weeks. Right. I put them on a cast and then start mobilizing afterwards.
And then trying to mobilize them afterwards. Okay. So you're obviously a trauma surgeon as well. So ankle trauma and other problems around the ankle can be a common thing. And I suppose if we start off with the simplest thing, someone spraining their ankle and they could end up with a ligament injury on the outside of the ankle, which is quite common. Often it's the ATFL. So the anterior talar fibular ligament, which is kind of the weakest area, isn't it, as the foot inverts. So on the outside, we've got those three smaller ligaments, but on the inside, we've got that big triangular ligament. So if someone sprains their ankle and they've had some physiotherapy, and what's your go-to with those sort of treatments? Do you always scan put an arthroscopy camera into the ankle as well if you're going to treat these, or do you just treat the ligament in isolation?
So there is it depends upon if it's the first time kind of a ankle ligament sprain or it is a chronic or recurrent ankle sprain. So the management is totally different for both of them. Acute sprains, obviously patients seen in A&E have been referred to orthopedic for us guys to have a look at it, and I tend to discuss with the patient the options of management. There is an evidence showing up that a complete immobilization for the first couple of weeks to 3 weeks is really, really beneficial, and there has been studies which have confirmed with the boot management and non putting anything, just so temporary period of immobilization will definitely help the ligament to heal up in a satisfactory position, and then start physiotherapy. I always give them about 3 to 4 months again of physiotherapy, rehab the ankle to get back the movements, to get back the proprioceptive thing on the and training the muscle around, especially the peroneal tendon, which is on the outside.
Yeah.
So what is the situation with this is I mean, you don't need obviously, unless it is a very unstable ankle when you examine to check, then obviously you might have to do an MRI scan. Ultrasound scan is good, but in the first 3 weeks you might not find anything much on that ultrasound. You might have to do it after about, once they've coming out, going for the physiotherapy to gauge how much of damage they've done to the ligaments around. You're right, the ATFL is the commonest one, which is, if you look into again here, that's around to the tip of the fibula in the front. There's one ligament. There's another one which is going at the to the calcaneum, which goes through across the hindfoot joint, and the one at the back. There's one at the back is more stronger. So commonest is the ankle sprain. You twist the ankle, rotate it, and you damage the ligament by pulling it. What happens is, in these ankles have not been properly dealt with, they go in for a chronic ankle instabilities, and so imagine this is keep going, tilting all the time. So you damage the cartilage underneath the top of the talus, that kind of ankle bone, and you get those kind of a pain. So assessing the patient properly and confirming the diagnosis, and then you can make a management plan. I've got a pathway of management of these ankle now. Over the years, we have designed a pathway where immediate management is rest, physiotherapy, and then most of them recover. 85% patients will recover by this physiotherapy alone. Those 15% will come back to a recurrent ankle instabilities and things, and then we image them with MR scan and see what else can be done.
And do you tend to use kind of implants to try and stabilize them, like the internal brace, where it's a little kind of fiber band that stabilizes it, or do you just do an anatomical repair?
Yes.
A Brostrom, Gould.
So it's always essential to, again, so it is important to examine the patient to make sure they don't have a multiple joint laxity, and they do have a multiple joint laxity, then I have low threshold to put some additional kind of a fiber tape or something around it to supplement the repair. But the gold standard is anatomical repair of the lateral ligament. It's again the day case surgery procedure, go home very same day. They got a brief period of plaster for a few weeks, and then boot after that. The management is usually, as you said, anatomical repair means you get the ligament back to back where they should be, and you tighten the capsule. It's called as Brostrom Gould kind of repair. That's a very common and quite routine kind of procedure. And we put some suture anchors into the bone to repair the ligaments. And again, at the same time, you have known that there is no damage to the lining cartilage of the talus or the tibia, and you then take a decision. If there is a damage to the so if they have a osteochondral lesion, that there's a damage to the lining cartilage on the tibia or the talus, which most probably is called as the osteochondral lesion or OCL of the talus dome, we'll get MR scan to evaluate how much of damage. And I would like to, before stabilizing the ligament, I do a cartilage kind of procedure on them by a keyhole operation. And then I'll offer to stabilize the ligaments. That's for chronic painful instabilities of the ankle.
So the osteochondral lesion, so basically it's the cartilage on the top of the talus bone, which forms part of the ankle, has been damaged, and on an MRI you'd see like a little dell really where it's been taken away. And again, it always, when you're doing an arthroscopy on this and you talk about micro drilling, and because it's almost like you're not doing anything other than scraping it a little bit in layman's terms and drilling it out. What are you hoping to achieve with that?
So basically, with the keyhole operation for these osteochondral lesion is you sort of assess the defect which is there on the and there's a classification which you find out after the MR scan to see how much of damage is on the cartilage. It's like a scuffing on the cartilage due to this chronic instabilities, and sometimes they can be all by themselves alone. The first line, once you have debrided or cleaned the lesion, wash the ankle, you do what microfracture is called as a bone marrow stimulation procedure. So you take a very tiny small drill or a small, which is called a microfracture kit, and you make a small taps into so imagine this could be a defect around the ankle here. So you make a 3 or 4, usually about 8-10 millimeters of sizes, and you do what is called, again, tapping into to allow for the bone marrow from within to come up and start the healing process. Obviously, it'll take about a few months before it can be completely, but they do very well with the pain relief in the first, because that's where the mechanical symptoms have been into the ankle because of chronic ankle going over on the ankle and an unstable ankle, and that causes the locking, clicking, and impingement due to the scar tissue and sometimes the bony tissue, which can lock that. And many people do develop loose bodies. It'll be interesting to see those kind of things.
So for those patients who have a large osteochondral defect, so a large defect in the bone, and it hasn't, and the microdrilling hasn't helped, there is this Oates procedure where you can take a bone graft and transplant it into there to recover the area. So sometimes people take it from the knee, and on the non-articular part of the knee, the bit that's not kind of part of the joint, and put it in. But the great difficulty about the ankle is actually getting into the ankle to put it in. So it ends up being a much bigger operation where you've got to break the tibia to try and pull the ankle out to put that in. Do you do that? Is that something you feel comfortable doing?
So what happens is these lesions can usually, give it plenty of time. To tell the patient it's going to be a patient's game. You need to be waiting for at least about 9 months, a year, and then you repeat an MRI scan, see how the progress has been. And many a times this kind of they start healing up very well with these micropressure good technique. If the defect has been larger than this and has been isolated, and then you can offer them what you said, the Oates procedure. But there is some newer techniques have come up now where you can sometimes avoid an osteotomy. So going into the talus, because everything is now completely covered here. You have to go there. You have to make a cut into that bone to flip the bone out, and then you can see it. On the outer side, on the lateral side, is very easy to bring the ankle down, and by just plantar flexing it while doing the operation, you can approach almost most of the talus. So most of the lesions which are there in the middle part of the talus and the front part of the talus can be approached without doing an osteotomy.
Without breaking it.
Occasionally, you'll need an osteotomy. You do that, and then you take a bone graft from the back of the calcaneum, or you can take it from the tibia, proximal tibia, and you can pack those cysts into the bone, pack it up nicely, and then a artificial membrane on top of it. So it can be done with the glue.
Okay. So, and do patients recover well if you've had to break the tibia? Then is that because it almost seems like that's a big operation to get over to actually get access, as opposed to you fractured your ankle, so we're going to fix it.
There's always will be a slight chance of delayed union or healing for these kind of, because your bone is not a controlled cut, an osteotomy, or with the tiny saw you make a cut into the bone and you move it across. With the newer techniques of fixations, and they're pretty good with a solid good kind of a screws, like a lag screw fixation on them, and they fix the bone quite nicely, and they're pretty good. Yes, you might offer them maybe just a couple of weeks of rest on these, and then start mobilizing the ankle.
Right, okay. So when people do twist their ankle and get problems like that, sometimes you can get another frustrating condition, which is fairly, again, non-specific, or sinus tarsi syndrome. So it's basically pain over the little anatomic sinus which goes through the foot, and there's not usually a lot to see other than tenderness over that area. And sometimes I find it can be associated with people who have flat feet. So when they have flat feet, they get impingement on the outside, and then it could be somebody who's had an injury and it's just never settled down. They feel unstable on uneven ground. And again, it's one of these things, you can sometimes pick it up on an MRI scan and it will show inflammation in the sinus tarsi. And you can inject it with a bit of steroid, or sometimes it helps. But is there any surgical options for that in your opinion? Because I always think that's a little bit of a wishy-washy poke and see what happens type of operation.
Funny, because this kind of diagnosis is really, most of the radiology colleagues make a diagnosis like a sinus tarsi inflammation or sinus tarsi syndrome kind of things. As it is a syndrome, people don't really understand very well, isn't it, these. So as you're absolutely right, many of these conditions are an effect of some irritation to the hindfoot. So sinus tarsi is around this side of the joint there. Can you see that in the middle? And again, if there is a subtle instability of the subtalar joint, it's very difficult to pick up on these on the clinical assessment. Very, very difficult diagnosis. Like you can have a damage to the subtalar joints. I've had situations where had previous operations, patients who have had a unstable ankle from before, where the CFL, that kind of ligament which goes from the lateral malleolus up to the calcaneum, that's at the back, and irritability around that joint can do that. Early synovitis arthritis developing into the subtalar joint, flat foot, and lots of other conditions can cause this. Patients who have got a by bone with an extra articular coalition. That means these two bones has to be separate, these talus and the calcaneum.
Yeah.
If they're not separated, there's a tether between these two bones, and they show these kind of things. So all these kind of complex things which people don't understand, they put it as a Sun-Starcer syndrome. But there's loads of things can do that. And the best way to approach them would be, in my practice, is to assess them under some kind of sedation or just an injection to the sinus tarsi. And that will help me a lot to see. For example, if there is a calcaneonavicular bars or congenital bars where there's been these two bones are never separated together, or supposed to be get some degree of flexibility, got running, playing football, suddenly twisted the ankle. So make sure there's no instability in the joint below the ankle joint, rather than, so everyone will say, oh, it's an ankle problem. It might not be an ankle problem. It might be a joint below the ankle called hindfoot, the subtalar joint. In those cases, I do a examination under anesthesia. If there's, and we examine both the hindfoot and then stress and give them injection to the sinus tarsi. So it's a complex thing where people have just mentioned it and lump everything up together into a sinus tarsi syndrome, but which is essential, could be teased out what exact diagnosis is. And the MR scan is very helpful in these situations as well.
Okay, so that, I suppose that leads us nicely onto the flat foot, really, which again can be treated conservatively. A lot of people have orthotic insoles, and back in the day, and you still see marketing that insoles change the position of the foot, which it doesn't really, because you can have a fully collapsed foot standing on a corrective insole. So realistically, we've come to the conclusion that insoles don't change the position of your foot, but they basically slow down the movement by applying an external force upwards. So as your foot rolls down and flattens, the orthotic or insole pushes it backwards, slows down the movement, helps with the pain, even though you're technically still flat-footed while still on an insole. But when you get to the ones that require surgical treatment, I think that can be quite a tricky thing to unpick in how to do it. What do you do for a flat foot in terms of how do you assess what type of operation you're going to do, and what type of operations would you consider?
Yeah, again, basically two broad categories of the flat foot patients. I'm maybe talking about adult acquired flat foot. Nowadays, the terminology is now changing to a progressive collapsing foot deformity. For the flex, in broad terms, it'll be two types. One is a completely flexible flat foot. Other one is a rigid flat foot, where there's hardly any movement in the heel. So all these joints around here, there's basically three joints called the talonavicular joint in the front, the joint subtalar we talked about earlier, subtalar joint, and the calcaneocuboid joint. Those three joints usually work in harmony together. And if the foot is completely collapsed in that fashion, the heel goes out of the position. So it has to be brought back underneath the heel. So if it is flexible, you can preserve the joints. A flexible flat foot can be preserved by like a joint preserving procedures. You do a heel shift to bring the heel back under the tibia, the leg bone, and do some tendon balancing. If one of the tendon which holds the arch in the foot is called the tibialis posterior tendon, which is on the arch inside of your ankle, and it holds this bone together up, the navicular bone up. And if that tendon is stretched and damaged, which mostly is, then you can replace by another tendon, or if the tendon is lost its excursion. If the tendon is intact, you can reinforce the attachment of the tendon, repair the ligament, spring ligament repair, and you do a calcaneal osteotomy to displace the bone inwards. So that's for a flexible kind of a flat foot. If the flat foot is rigid, then obviously you'll scan them first, MR scan, CT scans appropriate to. If it is a flat which is completely rigid, then you have to consider corrective fusion. Usually about two joints are enough, but like a double fusion, or some occasion you have to involve the calcaneocuboid joint. In my practice, I usually do a talonavicular or subtalar joint fusion. Start with the subtalar joint fusion, see how it is. The talonavicular joint, if need be, added on. And rarely I go for a calcaneocuboid, but yes, there are occasions where you have to block the calcaneocuboid joint as well.
Okay. I mean, I certainly, what I'm experienced when I'm teaching trainees is they do struggle with the concept of the flat foot on what to do, because there are so many planes of motion and so many different things. So when you're talking about a heel shift, what you're talking about is cutting the back of the heel and moving the back of the heel back under the leg, because if the heel's twisted out, you're kind of moving it back. You do get those patients that the heel looks relatively vertical, but the foot is collapsed and the foot is abducted away, so it's twisted this direction. So you look at them from behind, and they talk about the too many toes sign, so you can see too many toes from behind. So it's kind of a transverse plane, so moving in this plane. How do you address those? What's your go-to?
Yeah, so I think the most important thing is those are the additional procedures which will have to be done at the time of. So you need to. You're absolutely right. One is looking at the abduction of the foot. It's like the foot, like a banana shape. Is that the foot move out onto its lateral side? You have to address that, along with the foot goes into a supination. You have to bring it back into pronation mode. You have to bring sometimes an osteotomy in the mid part of the foot. So if the foot has collapsed and rotated outwards like this, you might have to do then address at the mid part of the foot, doing some kind of osteotomy to bring the foot down. So you may have to do additional procedures, which I think will be required. Not that common in my practice, but I sometimes do a lateral lengthening, which may be required for at the cuboid, calcaneal cuboid joint level.
And do you do it at the joint, or do you do it behind the joint?
Joint is much more preferable, and do it there. But what is becoming more popular now is a S kind of like a scarf osteotomy with the calcaneum.
Okay.
So you've got a Z cut onto the calcaneum, and then you lengthen on that side and shift medially as well. So that is one thing which is much more popular now, I think. We have to be careful with our own pitfall. That's an osteotomy of the heel which can lengthen as well at the same time move medially. So that's another thing which I think is growing popularity now. In my experience, calcaneal cuboid joint, like a lateral lengthening, although it's a good concept, but I think for elderly patients and things, it's not. There's a delayed time of healing. There's always some of the issue with the calcaneal cuboid joint fusion. Something will always be an issue with those. So I tend to avoid if I can. I address them at the talonavicular joint, slightly shorten them, and try to bring them more across medially. To achieve some degree of a deduction there at that level, but again, be very careful to rotate the foot down at the talonavicular joint level. So bring the heel back underneath, reduce it in a good position, check how heel has come back nicely, temporary fixation, then bring the forefoot back and close it around the talonavicular joint. And a Cotton's osteotomy, we call it, as a medial. So
that's at the cuneiform, medial cuneiform. So you're opening it up and
put a wedge
the metatarsal down to rebuild the arch. Have you ever used those little wedges, those metallic wedges that you can get?
Not metallic. I've not used them, but they are known now. People are coming up with some companies are coming up with those wedges. It seems a brilliant idea. But I tend to use the patient's own bone. Take some bone graft from either the iliac crest or from the back of the heel.
Right, okay. So when you're talking about the tendons then on the inside of the ankle, so you said tibialis posterior, the main strong tendon that holds the arch of the foot. And sometimes you'll see linear tears in that. Often it's torn on the undersurface of the tendon, so you flip it over and you can see it's torn, as opposed to it just being completely ruptured. You do get the ones that are completely ruptured. So how do you go about addressing that?
So when you open the medial side of the tendon, you look at the tendon itself. If the tendon is completely tendinopathic and torn, vertical splits and thickened capsule, everything, that tendon is not functioning. What I do is excursion test. I put a small kind of a suture material there and try and pull the tendon. If I pull the tendon, and if you see the excursion is going around the proximal bit, the tendon should not be sacrificed, in my opinion. So you can still salvage them, but additionally you might need additional strengthening procedure with another tendon. So if that excursion is not there, then tip post is not functioning, it's damaged completely. Then I think there's no point in that kind of a diseased tendon. There is some evidence showing up that if you keep that, there's still be painful. So you remove that diseased part of the tendon, cut the tendon out, and then you put a flexor hallucis, a flexor digitorum, FDS tendon in place of the navicular. So that tendon is next to it, and there's a very little kind of a disability. If they take that, harvest the tendon, it can be sacrificed safely, and all your patients will lose is that kind of a movement of the toes, but they still have the movement of the toe up and down. So that's a very good kind of a tendon transfer around the navicular. But obviously it's not as strong as the tendon patient is already damaged. So always warn them that even after the operation they'll need to have the arch supports and insoles for all the time.
Right, okay. So I suppose the majority of foot pathology tends to be in the forefoot, really. And the most common thing that we will come across is the good old bunions. So patients will come in and they've got bunions, and it might be that their big toe is starting to underline the second toe, and they've got either a toe that's crossing over, or they've just got pain around the joint. What's your assessment of a bunion? What's your goals for treatment in terms of that?
Yeah. So again, the proper history, the family history of bunions or not. Some patients will have hereditary bunions, and these are the ones that tend to recur back again. So you need to assess after the history, tend to assess the patients properly. Get a weight-bearing X-rays of the foot, which tells us exactly how much of the angle is between the two bones. So again here, so there is a damage. There is a more widening of the first and the second metatarsal. It goes all the way out, and then the big toe follows it. And there's always some degree of, almost always, there's a rotational deformity of the on the big toe called pronation deformity of the big toe, and that has to be addressed at the same time. The correction of the bunions, again, they're again looking at the radiographs. You have to then gauge whether it has to be a rotational element to it or just to shorten the intermetatarsal angle, and obviously relocate the displaced sesamoid bones, which is usually a degree of rotational element to it. It can be rotated back. So I do most of my practice of this is a standard kind of osteotomy around the first metatarsal, and if the joint is very lax in the midfoot and it's a very large intermetatarsal angle, I would offer them a corrective lapidus type of fusion. Basically, you're bringing these two bones together and locking them here at that level,
at the midfoot.
At the midfoot level. So that's a very very good, very strong correction. Slight downside to it. There's slight downside to everything, any operations, but you lose hardly. But it's a very very good correction and maintains the correction for a long time, and especially suitable for those who have very lax joints on these. So you can offer that kind of a lapidus. We always recommend assessing the toe see whether it needs a Aiken's procedure, which is a small twist to
straighten the toe.
It's like a cherry on the cake. We just want to do a bit more tidier to look cosmetically. It looks a lot better. But the gold standard for this treatment is to reduce the deformity at the first TMT and the intermetatarsal level, as well as the MTP joint. So these two joints are carefully preserved. Occasionally, you will have to do a release. For those bunions which have got a increased angle, like a congruent bunion, especially very difficult and tricky in the adolescent ones. So we have got those kind of things. Then you have to address what the double osteotomies. So those osteotomies are carefully planned, looking at the radiographs, patient's history, and all kind of assessment on clinical examination. I know these are getting more popular, the mini-invasive procedures, and that's getting more popular. I think I think you tend to do more of those mini-invasive work, but at the minute, yes, my practice is basically standard, which is gold standard for correction of the bunions.
Okay, so when you talk about the lapidus, so we're talking about the midfoot type fusion to stabilize the midfoot, and often you'll see patients with a severe bunion that's unstable that's also associated with a flat foot. So do you find that stabilizing that is enough to help to correct the flat foot, or do you combine some of your flat foot techniques with the bunion? When do you make that decision?
That's an interesting one. Yeah, it's interesting. The patient will have some subtle flat foot on these, and you're thinking, oh, shall I address this and that? Because that becomes quite a bit more difficult. Patients have just come for the bunion correction, so I tend to limit myself only to that kind of thing. Ask them to have insoles, and if you're slightly corrected over the first and the rotational component, especially the one when you rotate when you're doing a lapidus procedure, you rotate the first metatarsal, like you do a supination of the ray, and that brings everything relocates nicely, and a slight plantar flexion by doing the dorsiflexion to the big toe MTPJ, and that brings the ray slightly down, and that's good enough for them, and they'll feel a lot better. Obviously, they need to address the flat foot in case it's symptomatic at a later date.
I mean, sometimes I think it's almost you're treating the surgeon rather than a patient with some of the flat foot, because the surgeon sees the flat foot as part of the pathology, and there's that kind of decision making, isn't there, where the patient's not necessarily complaining of a flat foot, but some would argue that the flat foot is driving the bunion, and without addressing the flat foot.
Interesting you say that.
It's always a difficult judgment, I think.
If you look at them more carefully enough, you'll always find some degree of valgus to the knee as well.
Yeah,
so
exactly.
You might have got a genuine valgus, has got knock knees, and getting a flat foot, knock knees, all kind of a combination together. So yes, where do you stop?
Yeah, exactly.
So I think treat the most symptomatic in the thing first, and then let the patient be aware that these are things that are...
I often say we want to do the least invasive thing for the best outcome, but I suppose it's all, as I always say to patients, it's only ever the right decision once you've got a good outcome. because if it doesn't work, then somebody else would say, well, you should have done X, Y, and Z, but you don't know whether X, Y, and Z would do anything
exactly. So,
unless you did it.
Yeah.
You know?
So decision making is very, very crucial in all kind of, and especially more true for foot and ankle.
Yeah. Because there's so many
things can change, and you have to think on the spot.
Yeah. And I suppose another common thing that can be associated with bunions is well, what patients would have their doctor describe as metatarsalgia, which again doesn't mean a great deal other than pain in the forefoot. And I suppose there are two types for me of metatarsalgia. There's going to be that overload of the forefoot, those central 3 metatarsals, or it might be that there's disruption to the ligaments underneath, and that tends to come with a typical hammer toe where the bunion and the hammer toe, second hammer toe, come together, or it might be a nerve entrapment, a neuroma between there. And I suppose, again, teasing them out, which is better, using scans to tease them out. If you have those patients with kind of non-specific pain in the second, third, and fourth metatarsals, and it's not necessarily neuroma, and it's not necessarily associated with hammer toes, but you've tried everything such as injections and insoles, what do you do with those patients? Do you do anything, or do you offer
more than something? I would definitely confidently say more than 50-60% of patients will have gastrosoleus tightness.
Right.
So
okay.
Definitely,
so back to that.
Exactly. Yeah. So they have got a very subtle tightness of the gastrosoleus complex. All they need is a very, very good physiotherapy, stretching the program of the gastrosoleus. Pure, and then you're ruled out that kind of gastроsoleus issue. Then you come to address the medial ray. So the medial ray with them will be dysfunctional. I say it because if the foot works as a tripod, so for your foot basically on the big toe, on the little toe, big toe, and the heel. So we walk on this kind of a tripod. If the big toe is not purchasing nicely to the ground, there's a degree of hallux elevators lifted up, or it's not functioning very well, then you tend to overload the second, third, and the fourth. So you tend to load on the second, third, and you get a bursitis around the plantar aspect, then plantar plate get a bit of attrition, get a damage to the plantar plate, stretching of that, different grades of this, and you get those kind of deformities in these toes. Look at the x-rays carefully on these weight-bearing x-rays, and you'll notice that the second, third, and the fourth in these patients are a little bit taller compared to the rest ones, so that may need addressing and balancing. So these are talking about when they have failed all the surgical non-operative measures like insoles, offloading, and the very simple one like metatarsal bars in my practice is very common. I tend to give them that. I tend to do a gastrosoleus stretching program on them, good 3 to 4 months of physiotherapy, and then reassess them.
Do you ever do an isolated lengthening of the gastrosoleus just for that?
To be fair, Tony, many of these patients we had a physiotherapy. They feel I'm feeling a lot better now. I think it's a bit more better. I think you're right. We need to go for a metatarsal pads and carry on with them. And the patients have come back maybe good few years gone by, and they come back again. Those with the very obvious ones, definitely surgery, and they've gone beyond that level. So they've gone beyond the level of the tightness of gastrosoleus. They've come back with the isolated problem with the second, third, and fourth with the dysfunctional medial. If the medial ray is good, if the medial ray there is no hallux valgus, and many times they have got a hallux valgus like a bunion. It's totally asymptomatic.
Yes.
And they'll tell us.
Yes. So they come in with metatarsalgia, but the bunion is
completely symptomatic.
And then you've got that dilemma again, where you say, well, I need to treat your bunion, and the bunion doesn't bother me. And the problem I have with that, even though I still think it's the right thing to do to treat the bunion, is if the bunion doesn't work out and they get a complication, then you'll wish you never touched it, because they won't thank you for that.
So proper counseling the patient, proper consenting them. This is the situation. That's your afterload, overload because of the dysfunctional or hallux or asymptomatic bunion. Bunion is symptomatic, is causing the problem in second, third. So you document them properly. You tell them this is the issue. If they don't want you to touch the bunion at all, then I would at least, or you can do an Akins procedure, just a release and a bit of Akins to take the bunion off, and then you address the second, third, and the fourth. So second, third, fourth. In my practice, I think they have already I've ruled out all these kind of clinical kind of fine-tuned them all, checked them all, the gastrosoleus, the other issues, problems, tolerate. Then I address them surgically if need be. But obviously,
you shorten the metatarsals.
Yes. So before that, many of them will say, "Oh God, I've got a neuroma there." And that's a thing which is a bit of a issue where, yes, they'll feel better if you take the nerve out between the second, but it's very common. Primary neuromas are only common in the third and the fourth, not very common in the second, third. So if somebody is saying that I've got second, third, I've got the third and fourth, you're very, very cautious with them. So they don't have to come out all these nerves. And people come, I've got a Morton's neuroma. So that's the commonest thing being referred by the primary care. ultrasound scan is useful, and if you do ultrasound scan, they'll show us like a bursa there between these kind of things. So failing all those treatment, yes, I will do that. And if there's a taller ray, the second, third, and the fourth, then I'll balance them by a slight wall shortening kind of osteotomy.
So shortening them back. I mean, it's interesting you say about the neuromas, because when I was learning my minimally invasive surgery, I went to Germany and was taught by an orthopaedic surgeon there. And the first patient he had of the day was a patient who had neuromas 2, 3, 3, 4, and he was doing MIS, minimally invasive osteotomies to the second, third, and fourth metatarsals. And he said the patient doesn't like to have a numb foot, and I get where it's coming from that. And at the time, because I had no experience of doing the minimal invasive metatarsal osteotomies, I was kind of right, okay. But now I've done quite a lot of them, and to be honest, I've been absolutely blown away with them in terms of they don't look great on X-ray when you see them post-op because they're healing. You've broken the bone and it's healing by secondary intention, as opposed to what you're talking about where it's a clean cut and fixed with screws. But clinically, they work very exceptionally well.
Patient like it. They're very, very good. You're right.
It's actually completely changed my outlook on it, really. So because what I don't like about the wile osteotomy, the short osteotomy, which is open, is sometimes the toes float off the ground and it can be very frustrating. And I think it can be as 30-40% the toes sit off the ground, but you never get that with the minimally invasive one.
So what people should be doing for the wiles kind of osteotomy, it's not a true wiles kind of thing. You just take a very, because the saw itself can take about 2-3 millimeters off, and then you're taking another, it can lift it up a bit. You have to be careful with this, not to do. I mean, you just have to do a very thinnest saw blade, gentle release. Seems to work, but you're right. That's a well-known complication where the toe can be can lift a floating toe. Yes, the long-term effects of the MIS is still not very fully. Sure. They're getting popular. They're getting more and more popular, I think. But you're right. With hardly any tiny cuts around the toe, and mini-invasive is getting popular for the calcaneum osteotomy and supramallar osteotomy for arthritis in the ankle and all kind of things as well.
Okay. So I suppose to finish off, I mean, orthopedics is all about big joints normally, isn't it? And I suppose the big joint for foot and ankle is the ankle joint in terms of joint replacement, and that's. There's not many people do joint replacements. I mean, you do them, but in areas it tends to be one person who kind of does it because they're not done as often as, say, hips and knees. So when someone has a severe arthritis of the ankle, how do you decide whether to replace the ankle joint or just fuse the ankle joint? How do you work out what you want to do?
So this ankle replacement, as you said, is getting very popular now, and many of the people are getting good outcomes.
Because it had a bad press at one time.
Yeah, initially when it started off with these, and now we have seen the very good outcomes with these. 85%, almost close to 85% for 10 years, which is very, very good.
That's pretty good.
So people are doing it. What options do you have? If suppose you got a fused joint, a bad talonavicular joint, bad subtalar joint, already got some arthritis there. There's a bit of now the arthritis at the ankle joint. So if you fuse that joint as well, so everything's going to be very, very stiff, too stiff and very painful. So ankle fusion, although is a wonderful, good operation and a gold standard for managing ankle arthritis end stage in younger patients. But if patients were low demand, I mean, especially in my practice, I tend to choose them who have got a bit tired and not very, very active in that sense, but and have got a quite bad arthritis and without any obvious deformities and kind of severe deformities, would kind of a good candidate for an ankle replacement.
Right.
So we do the replacement for end stage ankle arthritis, but if it's very active, and obviously we'll get them to decide between both of these options. But if there is a definitely involvement of the joints around the ankle joint, then I would be more willing to offer a replacement rather than a fusion for them.
Right. And is there some age? Do you have age limitations and weight limitations on ankle replacements?
Usually, anyone above the BMI of 30 will be a bit of cutoff, but I think
that's quite low, really.
35 maximum.
I was going to say most people with BMI is more than 30.
Yes, so the patient is against the patient selection, isn't it? To a good outcome for these, and low demand, and it was more like a retirement kind of an age where not up and down the ladder that often. They'll wear it out very soon. So you have to be cautiously, although patients do come to my clinic and they're asking for a replacement. I said, I had a patient who was just asking only 36 of age and he's bad arthritis in the ankle. I want a replacement.
Right.
So it becomes you have to be properly. So when I do a fusion for these kind of situations in younger patients, I do arthroscopic keyhole surgery fusion for the ankle joint with only tiny cuts around it, and prepare the joint, fuse them with the screws, 2 or 3 screws, and then I don't take off the fibula or the
Yeah,
medial
so
side.
you
So I
keep
just
them
keep them
just
so that in case after 10, 20 years somebody wants to do a replacement for him, he can still
so
have
you
it.
could go back.
And you can.
Would you find that if somebody had their ankle fused, so there's complete rigidity then for a period of 10 to 20 years, and then you replace the ankle, do you feel that you would gain movements at the ankle?
I have not much experience on this at all, but I'd say some of my colleagues, because not many people have done it. It's a few and far now. People have started doing some of those which I've done before. It's a very complicated operation.
Yeah.
But the idea is you're not the message is when I do the fusion in young people, I don't tend to take out the fibula.
So you're trying to
preserve it, so
at least give them some options.
Some option in the future, maybe when they're more evolved, and we can still go back on these kind of fusions.
Yeah, brilliant. Well, thanks very much, Zain. I think we've proven that foot and ankle surgery is very complex, and there are multiple avenues of treatment available to us. So if someone wants to get hold of you to come and see you in your practice, how would they get hold of you?
You need to get in touch with the Coriel Orthopaedic group where I practice, and they can either contact our secretaries to book an appointment.
Yeah, brilliant. Thanks very much.